Hello. Today we're going to be talking about inflammatory and structural disorders of the heart that result in inflammation and decreased cardiac output or decreased blood flow, which results in altered tissue perfusion. The objectives for today are to describe the etiology and the pathophysiology of the different disorders, discuss the collaborative care and nursing management. We're going to be looking at endocarditis, pericarditis, and several different valve disorders, and a little bit of cardiomyopathy, pathophysiology care, and collaborative care. Today we're going to be talking about infective endocarditis, and the concept that we're really talking about here is inflammation. Infections and inflammatory diseases have multiple etiologies, which makes it very difficult to diagnose. Now let's take a look at the etiology, pathophysiology, and some of the classifications of infective endocarditis. So, what is it? It is an infection of the endocardial surface of the heart that includes the valves. It can be caused by a bacteria, a fungus, a virus. The most common infecting organisms are Staph aureus and Strep viridans. These are organisms that are commonly found in the mouth, on the skin, and in the GI tract. So, etiology, who is most susceptible? Who is at risk for developing endocarditis? Anybody who has damage to the endocardial lining of the heart, including the valves. This would be anybody who has a valve problem, a murmur of some sort, IV drug users, somebody who has a prosthetic valve that's been replaced, anyone who's had surgery within the last 60 days, particularly dental surgery, in which case bacteria, occasionally when you have dental surgery, bacteria enter into the bloodstream. It might only be, the bacteremia, they say, the bacteremia might only exist for like 15 minutes before the immune system can handle it, but it's still enough to do a little damage. So when we're talking about the pathophysiology, we have a lining of the heart, particularly the mitral valve is affected, that has some damage to it. And this damaged endothelial lining exposes the basement membrane of that valve to turbulent blood flow. So what happens is there's damage, and we know that the endothelium usually does not allow platelets to aggregate, and it does not allow white blood cells to aggregate. But when we have damage to that endothelial lining, we have some inflammation. And in that inflammatory response, you'll remember that there is this hypercoagulable state. So we have a lot of platelets and fibrin that come to the area that is damaged, and those platelets and fibrin, they kind of stick there on the valve. And then the body has some sort of an insult, like there's a portal of entry, as in the person was an IV drug abuser and a bacteria got in, or there was a dental procedure or a cystoscopy that happened, a cystoscope, where they're looking at the bladder, and a bacteria enters into the bloodstream, and that bacteria circulates, and then it finds its way to that damaged valve. That we had a damaged endothelium, and because of the damaged endothelium, platelets and fibrin gather there, and then a bacteria comes and it lands on that platelet fibrin clot, and the immune system and the inflammatory system kicks in, and that the white blood cells and the macrophages come to that damaged area where the bacteria is. And so now we have platelets sticking on there. I have a bacteria that's on there, and the bacteria start to proliferate. And now I have white blood cells, macrophages, monocytes rushing to the area. And then when I have, as part of the inflammatory process, I have more platelets that are growing on there. And what happens is the valve, you see, has... So here is a picture of a mitral valve that has vegetation. You see that arrow on there, that is the vegetation. There's a valve, and that is a whole big clump, a whole big clot, kind of looks like cauliflower, of fibrin and platelets and bacteria and white blood cells, and they are hanging on the valve. And I'm using the example of the mitral valve in this case, which is the most affected valve. And they're making it very difficult for that valve to work. There's a lot of turbulent blood flow that's rushing past that valve that has all these vegetations hanging on it. For those of you that are visual learners, here is a chart for you to take a look at, but this is just a chart representation of what I'm going to say. So we have that valve that has all those vegetations on there, and those vegetations interfere with normal valve function, and eventually they damage the valve. They can damage, imagine the valve is supposed to be opening and closing as the blood is flowing from the left atrium to the left ventricle, or from the right atrium to the right ventricle, and it causes damage to the valve, the chordae tendineae, the little muscles that move that valve. They get stretched and they stop working, and the vegetations can cause damage. They can cause erosion or perforation. And that erosion, perforation, the valves not working properly can lead eventually to signs and symptoms of heart failure. In addition, those vegetations are unstable lesions, if you will. So they're hanging on the valve, and little pieces of that vegetation could break off and cause an emboli. So let's think about the emboli. If the mitral valve is the one that is the valve that's affected and has the vegetation on it, and a piece of that vegetation breaks off, it's going to shoot, that vegetation is going to move right from the mitral valve right through the left ventricle and out to the body. And when it goes out to the body, it can cause an MI, it can cause a stroke, it can cause a DVT. If the valve is on the right side of the heart, like often the valve that's affected for... Now let's talk about clinical manifestations and the diagnostic studies to determine if someone has infective endocarditis. Something that I didn't say to you is Most endocarditis happens over a long period of time. There is damage to the endothelium and there's platelets, and it takes a long time for that vegetation to grow. So we call that a subacute endocarditis. There is very rarely there is acute endocarditis, in which case there was still damage to the endothelium, but the vegetation grew very quickly and the person presents with signs and symptoms of heart failure. That is much more uncommon than the subacute form, where it's just slow and insidious. It just kind of comes on over time. People don't really know what's wrong with them. So let's have an example of that subacute form. The person might have a low-grade fever, chills, fatigue, maybe some night sweats, but they recognize those things as, oh, I have the flu. I'm just not feeling well the last little bit. We begin to see signs of a new or a changed murmur. You need to put a star to that because that's kind of one of the things. So a person has flu-like symptoms, but suddenly they have a new or a changed murmur, which indicates that there's something wrong with one of the valves in their heart. We may even see beginning signs of heart failure. What are those beginning signs of heart failure? They might have some fluid retention. They might have some orthopnea. They might have weight gain. Maybe a cough that they can't, that they don't know where it came from. But of course, then they're relating those symptoms to their flu. So when we hear flu-like symptoms, we have a new or a changed murmur. We might see signs of clubbing of the fingers because it's been coming on for a long time. And there is some heart failure and there is some poor perfusion. So we see that clubbing. We might see splinter hemorrhages or petechiae in the mouth or the conjunctiva, maybe even the upper chest. So these little splinter hemorrhages and these little petechiae are coming because there's little pieces of that vegetation that are breaking off and getting into the small capillary beds and causing little splinter hemorrhages, they call it. We could also see in terms of clinical manifestations when it is been a long time in this subacute form. There's something called Osler nodes, and these are small raised bumps on the fingers that kind of look little red raised bumps on the knuckles of the fingers. You can see pictures of them in your Lewis textbook. Or these, they call them Janaway lesions, which are like purplish bluish spots that come on the bottom of the feet particularly, or on the palms of the hand. Again, you can take a look at those in your Lewis textbook, or go ahead and Google them and you can see them. Other signs and symptoms that we might see would be secondary to an embolism. So we said that if the lesion, if the vegetation is on the right side of the heart, it's going to blast off and it's going to blast into the body. So we might see it manifested as a stroke. We might see it as a DVT in an extremity, like an arm or a leg. We could often, these vegetations will go and they will clog up the renal artery, in which case we will have flanking and maybe some hematuria. We can also see it manifested in the splenic artery, and that would be a sharp shooting left upper quadrant pain if the spleen is affected. Now, if the lesion is on the right side of the heart, we're going to see that manifested as a pulmonary embolism. And of course, you'll remember that a pulmonary embolism will be severe shortness of breath, pain, Person will have a sense of agitation and a sense of impending doom. Now let's move on to the diagnostic studies. Okay, so we remember that flu-like symptoms with a new or a changed murmur are going to be critical elements to determining. Another thing we're going to see is that the person will have a persistent bacteremia. That means that they have bacteremia, they have bacteria in the blood, and there's evidence of myocardial involvement. So when we are diagnosing, we are going to have blood cultures from two different sites. Now, in the subacute form, they want blood cultures from two different venipuncture sites at 12 hours apart over 24 hours. In an acute form, we would want two sets of blood cultures 30 minutes apart from two different venipuncture sites. And immediately following the blood cultures, we will start antibiotics, which we'll talk about on the next slide. Okay, so we have that fever, new or changed murmur, bacteremia, confirmed by venipuncture, two different sites. We will probably see a mild elevation in the white count. You know, normal white count is 5 to 10. It might be like 11,000 or 12,000, something like that. The sedimentation rate, your SED rate, will be elevated. C-reactive protein, indicating that there is inflammation and there's an inflammatory response going on, that's going to be elevated. How are we going to know that there's cardiac involvement? Well, we're going to do an echocardiogram. We're going to be looking for that intracardiac vegetation. We might even do a TEE, a transesophageal echocardiogram, to give us a 3D view. There might be a chest x-ray, especially. Now I want to talk about the collaborative care and drug therapy. What are we going to do with the person with infective endocarditis? Okay, so we said that the person will have these venipuncture, they will have blood cultures, and immediately following the blood cultures, we will start the person on an antibiotic, a broad spectrum antibiotic, awaiting the results of a culture and sensitivity test to make sure that the person's on the correct antibiotic. They're going to be on an antibiotic. They're going to be on an antibiotic for a long time because we have a lot of entrapped vegetation down in there, and it's hard for the antibiotics to get through all the platelets and the fibrin and all the bacteria trapped in that vegetation. So it takes a long time, and we'll start them on an antibiotic in the hospital, and these people will go home with a PICC line, and they'll be managing their own antibiotics at home. A home care nurse will be coming out to change the dressing on the PICC line and make sure that there's no signs and symptoms of infection. And then they'll probably come off of that antibiotics after a couple weeks and take some oral antibiotics. We do a lot of teaching about not stopping the antibiotics before you're told, because we don't want to make resistant organisms. And like I said, this is very hard to treat, and there's often relapses, and and the disorder reoccurs. With that being said, we try several weeks of antibiotic therapy to try to completely eradicate the organism. But the person will have a lot of peak and troughs. One of the antibiotics that we like to use is a vancomycin, an aminoglycoside. So when I say aminoglycoside, you should say immediately to yourself, wow, I really have to be watching the kidney function, because aminoglycosides are nephrotoxic. And when we talk about aminoglycosides, we have to have therapeutic dosing. So you would expect peak and trough levels to be done routinely to make sure that we're handling that appropriately. We will be using Tylenol or Motrin, NSAIDs, to treat the fever. Lots of fluid and rest are in order, because remember, this heart is having trouble functioning because the valve is damaged and all this vegetation hanging on. So we want to have rest, which is very important, because we want to decrease oxygen demand. We want to decrease the workload on the heart. Anticoagulation is going to be started for this person, because we don't want to develop any blood clots on that vegetation. In some cases, there will be, if there is severe heart failure or there is significant valve dysfunction or a perforation, it may be necessary for surgical intervention. So in terms of your nursing assessment, you're going to be doing vital signs. You're listening for a new or a changed murmur. You're going to be inspecting the oral mucosa, the conjunctiva, the anterior chest. You're looking for petechiae. You're looking for signs and symptoms of complications of an MI. Nursing diagnosis, you might use decreased cardiac output or altered tissue perfusion related to incompetent valves, risk for injury because of the emboli, activity intolerance, hyperthermia because of the fever. So these are all things that you're going to be taking a look at. Now I have down there prophylactic treatment. Years ago, anybody who had a murmur of any sort, they took antibiotics before different procedures. But it's not that way anymore. Some physicians, I understand, some physicians are still treating that way, but they're just out of date. What is recommended now? What is recommended is that those who are at high risk patients are considered patients who have a history of endocarditis or people who have a prosthetic valve. If you are one of those people, then this is what we say. Antibiotics before and sometimes even after dental procedures with gum manipulation. So gingival, the gums, gingivitis, gingival manipulation. Anyone who has a tonsillectomy or adenoids. If you're going to have surgery to the respiratory mucosa, bronchoscopy, a cystoscope, or any kind of urinary manipulation for a patient with an enterococcal infection, and any surgery of infected skin or musculoskeletal infection like osteomyelitis. One more word about endocarditis before we move on to pericarditis. Those patients that are at high risk, those that have a history of endocarditis and those that have a prosthetic valve, we have to do a lot of teaching about oral hygiene. And what are we going to teach them? We're going to teach them that they need to use a soft toothbrush, and they need to brush their teeth with a soft toothbrush and toothpaste at least twice a day. They have to brush their teeth, their gums, their tongue, and the whole oral mucosa. They are use an antiseptic mouthwash for 30 seconds in between brushings. We teach them no toothpicks, no nail biting, no body piercings, no branding, no tattooing. For females, we teach them no IUDs for birth control. We tell them to report any fever that lasts longer than 7 days. We also remind them, do not start antibiotics unless you're told to do so. Don't stop antibiotics unless you're told to do so. And as nurses, we know we are vigilant with the asepsis. We are watching all caths, all tubes, all drains. We want to get all of those things out of the body as soon as we can, but we know that it is critical that we minimize those portals of entries for these people that are at high risk. Now let's talk about acute pericarditis. Okay, what is acute pericarditis? Well, you know that the pericardium is a fibroserous sac that surrounds the heart. Its job is to support and protect it. We know that pericarditis is an inflammation of the pericardium. It usually lasts about 1 to 2 weeks. The inflammation often involves the adjoining diaphragm. So what happens? The bacteria or a pathogen attacks the pericardium, and as that bacteria invades the pericardium, the body's natural response is for the inflammatory response to kick in. So in the inflammatory response, we remember that histamine and other cytokines are going to cause vasodilation, and they're going to change the permeability of the vessels. And then those vessels are going to leak protein-rich formula or protein-rich fluid into the pericardium there. It's going to cause edema. It's going to cause fluid buildup. We know as part of the inflammation. We teach the math in the class and put questions on each test, period. The math test goes to the clinical course such that they have to pass a math test before they can go to clinical. Okay, so I just flipped the slide. We've been talking about the etiology and pathophysiology. We said that bacteria enters into the pericardium, and as a part of the normal inflammatory process, we have histamines and cytokines. The histamine changes the permeability of the vessels, and we have allowing albumin or a protein-rich fluid to leak out, and as it leaks into the pericardium, as the albumin, the protein, leaks out of the vascular space, it's going to pull more fluid with it. We have cytokines that are going to call all of the good cells. Remember, the cytokines are the sound the alarm system for the immune system. So we're going to have all those local macrophages that are there, and they're going to begin to engulf the bacteria. And then the immune system is going to bring more neutrophils and macrophages and monocytes to the area. And as all that fluid is leaking into that pericardial area, fibrin and macrophages and the bacteria and the albumin, we start to form a large exudate. So fluid is building up. And the concern that we have is that that fluid builds up, and we can have a pleural effusion. As that fluid builds up around the heart, we are concerned about cardiac tamponade, so the fluid builds up and presses on the heart. It presses on the heart so much that the heart can't expand and contract. It can't beat like it's supposed to, and we can get cardiac tamponade or signs and symptoms of heart failure. Well, who's at risk for developing pericarditis? Well, 90% of pericarditis is idiopathic. That means that we don't know where it comes from or why the person got it. It's presumed to be viral. We can have autoimmune causes of pericarditis, which can be caused by lupus. We can have, it can be inflammatory. They call that Dressler's syndrome. That's where the person will develop fever and malaise. The white blood cells will be elevated for a couple weeks to a month. And this is post-MI. So that's a common complication post-MI. It's thought to be autoimmune. Other causes of pericarditis, acute pericarditis, neoplasm, acute radiation to the chest, surgery, chest trauma can all be causative factors. Clinical manifestations. Okay, so we have severe, sudden, stabbing chest pain that often radiates from the back or the arm. It is aggravated on deep inspiration, so when the person takes a deep breath. It is aggravated when they lay back or cough. It's relieved when they take shallow breaths or they lean forward. And the person will probably have some fever and malaise. We will also hear a pericardial friction rub. It may or may not come and go. We can hear it best when the person leans forward. We listen on the left sternal border would be the place that we can hear it the best. And we have a pericardial friction rub versus a pleural friction rub. So a pericardial friction rub, if we ask the person to hold their breath and we still hear the friction rub, it's coming from the heart beating. If when the person holds their breath, the rub goes away, then I lost my train of thought, sorry. If the person holds their breath and we hear the murmur or we hear the friction rub, we know it comes from the heart. If when they're holding their breath, it goes away, we know that it's coming from the lungs. Okay, let's talk about diagnostic studies. Well, we'd like to get a 12-lead EKG. Certainly a CBC, we're looking for infection, inflammation. We want to get cardiac enzymes to see is the chest pain coming from an MI or is it an inflammatory process. We'll get blood cultures. We want to do an ANA. We want to get a SED rate for these people. And lastly, on this slide, collaborative care. What are we going to do? Well, we have to treat the symptoms. And treating the symptoms is mostly pain. And because this is an inflammatory process, we are going to treat, it's not an infectious process, we are going to treat with NSAIDs, right? So maybe like something like Toradol or Motrin. And when you hear NSAIDs, you're thinking to yourself, oh, I have to protect them. So you're going to have like maybe a PPI or a histamine blocker or something like that. Now we're going to shift gears a little bit and we're going to be talking about valvular heart disease. The valves most frequently affected are the mitral valve and the aortic valve. The different conditions that we can have, valve disorders, these are structural. Let's think about stenosis. Okay, so stenosis, they say this is a stenotic valve, this is a stenotic mitral valve. And let's talk about the way valves work. Valves are made up of leaflets. either 2 leaflets on the mitral valve or 3 leaflets on the tricuspid. And the job, they are very thin, paper-like flaps. And what happens is the blood, this is a mitral valve, so I'm going to talk about the mitral valve. The blood comes from the left atrium, and these little leaflets, these 2 little leaflets, they move very freely and very easily, and they open up like a gate. They open up and they allow the blood to rush from the atrium down into the ventricle. And when the blood gets down into the ventricle, that gate closes, or those flaps close. And when they close, they make a nice tight seal so that the ventricle can fill up and then squeeze the blood out in the body. When we have a stenotic valve, they say familiar fish-eye appearance is what you'll read. And so you see that that valve is thick and narrow, and it doesn't close tightly, and the floodgates don't open very easily. So it's very hard for. Okay, so I just said this stenotic valve, this thick, hard, narrowed valve, makes it very difficult to get blood from the left atrium into the left ventricle. And like in heart failure, where we talked about the heart working very, very hard, and when the heart works very, very hard, what happens? Like any other muscle in the body, it gets big and it gets thick. The atria, in this instance, the left atrium, is working very, very hard. It's squeezing and pumping and trying to get blood through. So as it squeezes and pumps, and over time, it's going to get big, the atrium, the left atrium, big and thick and hard. And the pressure inside that atrium is going to get very high. And when the pressure in that atrium gets very high, it's very hard for the blood to get into that atrium. So what happens? Like in heart failure, it backs up into the pulmonary circulation, and pulmonary pressures increase. So let's think about when we talked about heart failure. So here we have a stenotic valve. It's not allowing the blood to get from the left atrium into the left ventricle. So what happens? There's a little bit of blood coming out of the left ventricle. We have a decrease in cardiac output. And in addition, the left atrium was getting big and thick and hard, and the pressure inside of there is getting so much that the blood backs up into the pulmonary vascular bed. And when there's a lot of blood in the pulmonary vascular bed, another way to say that is that we have high pulmonary hypertension, right? There's a lot of pressure in there. And what happens is the right side of the heart, the right ventricle, is trying to pump into that high pressure system. Remember that the pulmonary vascular bed is a low resistance system. There's not a lot of resistance out there. So what happens is the left ventricle is working super hard, and it's getting big and it's getting thick and it's getting hard. And then the blood backs up from the from the right ventricle into the right atrium, and from the right atrium out into the body. So we're going to see it manifested as right ventricular failure. So let's talk about the clinical manifestations. Okay, so initially, the person will have this mitral valve, and the heart will be working harder, and it will do a good job to compensate. We'll have increased oxygen demand. We'll have an increased workload of the heart because the atrium's working so hard. But when we begin to see signs and symptoms, we're going to first see some pulmonary symptoms, some signs and symptoms of pulmonary hypertension. So, fatigue, dyspnea, orthopnea. We're going to hear a murmur because you're going to hear the blood trying to get through the turbulent blood flow trying to get through that stenotic valve. Lots of times we have an irregular heartbeat, palpitations. AFib is very common. But as time progresses, So we have that fatigue and orthopnea. We kind of look like we have early signs of left-sided heart failure, because we really do have signs of left-sided heart failure. Then we begin to see hemoptysis, right? They start, just like in heart failure, coughing up blood. They might have angina related to the decreased cardiac output, the decreased amount of blood coming out of that left ventricle. We have a lot of stasis inside the blood, inside the heart, because we're not pumping the blood out. So we might see signs and symptoms of a stroke, maybe even emboli. And as the disease progresses, we'll see signs and symptoms of right-sided heart failure with edema and JVD and all. Now, the thing is that when we talk about treatment, we will be talking. Now let's switch gears and talk about mitral valve regurgitation. We said that the mitral valve is supposed to be these two little leaflets that are paper thin, and they move very easily, and blood comes from the left atrium, moves through these little valves, or through the valve, and then leaflets, they close nice and tight like a Tupperware bowl. No fluid can come back. The ventricle can fill and it can squeeze, and we have maximum cardiac output. With regurgitation, we have a leaky valve. So this leaky valve, what happens? So the blood comes from the right atrium, from the left atrium. It goes through the valve and it moves into the left ventricle. And then we're supposed to close the doors, right? They slam shut, that gate closes so that the ventricle can pump. But in this instance, we have a leaky valve. The leaky valve allows blood to backflow up into the atrium. And both the atria and the ventricle have to work really hard to preserve cardiac output. There is extra volume that the atria has to try and push. So the atria is working really hard, and we get this atrial enlargement because, so let's just say 1 cup of blood supposed to go from the atrium and move into the ventricle, but a 1/4 cup backflows. So now what we have is we have the left ventricle. It's working really hard because it has to maintain cardiac output. That's what it has to do. So it's going to be pumping very hard. We are going to have 1 1/4 cups up in the atria. So the atria is going to try and push 1 1/4 cups down into the ventricle. Now we have this extra volume between the atria and the ventricle. We have atrial enlargement, we have ventricular dilation, and we have, after time, if we let it go on, that will lead to left-sided heart failure. Who is at risk? People who have had infective endocarditis, anybody who has mitral valve prolapse, which we'll talk about in a minute, people who maybe have had an MI or who had rheumatic heart disease when they were a child. You will hear a murmur for these people. Again, signs and symptoms. Initially, you won't see any signs and symptoms. And our treatment goals will be to control the signs and symptoms and intervene before the person has heart failure. But again, it will look like, if we let it go too long or it's untreated, it will begin, the left side of the heart will fail. And as the left side of the heart fails, we will have signs and symptoms of left-sided heart failure, orthopnea, fatigue, dyspnea, and eventually, if it continues, we will have right-sided failure, giving us signs and symptoms of weight gain, JVD, and edema. Then there is mitral valve prolapse, the most common structural defect of the heart. People have it for years. They don't know they have it. You know, they had it since they were a child, and they're 65 years old, and they go for some sort of a study, and they're like, hey, did anybody ever tell you have mitral valve prolapse? So the etiology is unknown. We really don't know why. It's, like I said, usually benign. Complications could be mitral valve regurgitation or infective endocarditis, or maybe even ischemia. You may or may not hear a murmur. What is mitral valve prolapse? This is a nice little picture of it. See, we're supposed to have the two little leaflets that work very easily, and they close nice and tight. Well, with regurgitation, it was like leaving the back door open a crack, or not putting the lid on the Tupperware bowl as tight as you could, and it leaks. It's leaky. With prolapse, one of those leaflets actually flaps up into the atria. So the blood comes from the left atria into the left ventricle, and we're supposed to have the door slammed shut, the gate slammed shut, but instead it swings back up into the atria. Like I said, in most instances, it causes no problems whatsoever. A complication would be that you get some regurgitation, so that you get that backflow of blood there. And I like this picture because it shows you can see that left ventricle. This is a mitral valve prolapse that had some regurgitation involvement, and you can see the etiology. Like I said, we don't really know where it comes from, and clinical manifestations. In most cases, there are none. In cases where it's going to cause a problem and going to cause regurgitation, if we let it go too far without being repaired, then we're going to see signs and symptoms of left-sided heart failure. Aortic stenosis, like mitral valve stenosis, is a thickening, a shortening, a narrowing of the valve, which makes it very difficult. Aortic stenosis is a fairly common structural defect. It can be congenital, or it can come from rheumatic heart disease, but it is thought to also come from wear and tear. Just using it too much for a lot of years. So it is a fairly common problem in the older population. So just like with mitral valve stenosis, the aortic valve is thick and short and small and narrowed, and it makes it very difficult for the left ventricle to pump the blood out of the left ventricle into the coronary vessels. So we will get left ventricular hypertrophy. We talked in heart failure, talked about hypertension causing increased workload of the heart, increased oxygen demand of the heart. Well, aortic stenosis can cause heart failure as well for the same reason. It's not vascular resistance that's making the workload of the heart. It's this stenotic valve that increases the workload of the heart. So we have an increase in oxygen demand related to the pressure that the heart has to overcome. We related to cardiac mass because we're getting hypertrophy. And once the body will compensate by, when cardiac output is down, we will increase the sympathetic nerve, just like we did in heart failure, increase the sympathetic nervous system. We will increase the heart rate. We will increase the work of the heart. We'll be squeezing, and eventually when the compensatory mechanisms fail, it will lead to decreased cardiac output and pulmonary hypertension and heart failure. In terms of signs and symptoms, we have the aortic stenosis. We call it the classic triad of angina, syncope, and exertional dyspnea. That means when the person is exercising, they'll be dyspneic. The person will have a murmur. Now, in terms of treatment, we do not want to give our patients with the aortic stenosis, unlike heart failure, we do not want to give them nitroglycerin nitrates, because we need to keep afterload up to keep the valve, to help keep to allow that extra pressure to open that very stiff aortic valve. These people do have permissive hypertension, so we want to keep vascular resistance. Aortic regurgitation. Just like regurgitation of the mitral valve, we have this little flap that doesn't close tightly. The Tupperware bowl doesn't seal. The door is left open, whatever you want to say. So we get retrograde blood flow from the ascending aorta into the ventricle, which results in volume overload. And at first, we can compensate with left ventricular dilation, and then that ventricle has extra blood in it, so it will be working extra hard, and we will get hypertrophy, and then that hypertrophy will cause an increase in pressure in the left atrium, and then the blood will back up from that left atrium back to the pulmonary vascular bed, and from the pulmonary vascular bed, that will cause right-sided heart failure because it's working so hard. So again, our goal would be to treat these patients before they end up with signs and symptoms of heart failure. But sometimes, because a lot of these patients with aortic regurgitation and aortic stenosis, a lot of them are poor surgical risks. But we're going to talk about some treatments for valve disease in a couple minutes, and we'll see that there's very new, non-invasive things or minimally invasive procedures that we can do to help these people. So when we talk about regurgitation, I also want to talk about life-threatening aortic regurgitation. And that is with aortic dissection. And aortic dissection, we know that the lining, that the blood vessels are made of several layers. And sometimes we have a dissection, often related to coronary artery plaques. So you'll recall that with coronary artery disease, we have lipids that are able to embed themselves in the endothelial lining, and then we have foam cells that get in there, and first we have a fatty streak, and we have macrophage entrapment, and platelets that are aggregate, and then we have lipids that are all surrounded by this fibrous cap, they call it. So we have a calcification, and that calcification is on the endothelial lining. And it's narrowing the blood vessels, and the blood comes out of the heart, and it's pumping past there, and it's very turbulent. Well, once in a while, the blood will grab a hold of this plaque and rip it. And when it rips it, sometimes it doesn't rip right through all of the layers of the vessel. It just rips one layer away. And so it's out there, and the blood goes down, and it rushes between the outside lining of the vessel, gets down in between the endothelial lining, which is ripped, and it makes a roadblock. And the blood comes out of the heart, and it rushes down, and it hits this roadblock all of a sudden, and then the blood has retrograde flow and blasts back through the aortic. Well, I didn't advance the slide, but I said all this stuff on the last slide. Sorry about that. All right, let's talk about diagnostic studies for valvular heart disease. Let me just say this. Remember that all of the valve disorders have basically the same signs and symptoms. We will hear a murmur early. We have dyspnea. The early signs, maybe some angina. Arrhythmias are common with these valve disorders, so AFib is the most common. And most of these things, most of these disorders, because most valve disorders are on the left side of the heart, the aorta and the mitral valve. So the early signs will be fatigue and dyspnea and orthopnea, early signs and symptoms of left-sided heart failure. And as they progress and the left-sided failure gets more and more, we will then begin to see signs of right-sided heart failure, because all that pulmonary hypertension was leading to extra work of the left or the right side of the heart. And okay, so let's talk about things that we're going to do for these. First of all, we need a good history and physical. We are asking a lot of questions about past medical history. Did they have infective endocarditis? Did they have rheumatic heart disease? Have they had any kinds of surgery? So these are important questions for us to ask. We want to get a chest x-ray. That'll tell us if there is any cardiomegaly in there, so any hypertrophy that might be happening. We'll get an EKG. We will want to get an echo. We can have a straight echo. We can have an echo with 3D Doppler. That way we can see what's going on in there. A TEE. In some cases, we can have a cardiac cath for diagnosis. Exercise stress test. This gives us a lot of information about the way the heart is responding and the cardiac output, ejection fraction, all of those things. These tests will help illuminate that. Okay, so interventions, medications. Well, we're going to see a lot of the same medications used to treat valvular disease when the patient becomes symptomatic as we use with heart failure. So we'll see ACE inhibitors, we'll see beta blockers. We might see the use of ionotropic agents such as DIG to increase the contractility of the heart, diuretics to decrease the workload of the heart, anticoagulants. We might need to drugs, calcium channel blocker, amiodarone, to treat AFib if that's a problem. And certainly rest, fluid restrictions, all of the same things that we would do for heart failure. And then here I have down here this percutaneous transluminal balloon valvuloplasty. So what is that? That is a minimally invasive procedure where they go in usually through the femoral artery, and they have a catheter that they drive in there all the way up to the affected valve, and there's a balloon tip catheter that they put in there, and they blast it open. So this is they use for a stenotic valve. They blast that open, and it's not curative, but it will buy some extra time for the person. In some instances, it could last several months, and sometimes even only several weeks, but it is temporary symptomatic relief. In the most severe cases, we do valve repair, where they go in, especially if somebody's had infective endocarditis, where they can go in and repair the leaflets. Your textbook has some different pictures of some of the procedures that are done. You don't need to know the individual procedures, just know that they can go in there and they repair the valve with different types of procedures. We can do valve replacement, where they are replacing it with different mechanical valves or bovine valve or a porcine valve. Remember that if there is kind of valve replacement, that they will be on long-term, lifelong anticoagulation to prevent any thrombus formation. There's a new procedure within the last couple years. I know you've probably heard it on the TV and radio. St. Mary's Medical Center runs a lot of ads about TAVR, the TAVR procedure. And this is transcatheter replacement. So they are doing valve replacement or repair, I guess you'll call it, where they take, where through femoral access, they take a catheter. Here's some pictures of the different types of valves that you can hear. Remember, these are mechanical valves. These people are on lifelong coagulation, anticoagulation. Okay, so in terms of nursing assessment, we are concerned about decreased cardiac output. We're concerned about gas exchange, activity intolerance. We're concerned about fluid volume overload, and a lot of health promotion for these people, teaching about signs and symptoms of right and left-sided heart failure. These patients are cared for at home because remember, angina, dyspnea, syncope are common, so they really interfere with activities of daily living. And we talk about if you are somebody who's not a surgical candidate, then we talk about how to conserve your energy and the medications that you need to take. And we are concerned, particularly people with aortic stenosis, we're concerned about the syncope. There's a lot of support groups out there. The American Heart Association has a support group called Mended Hearts for people who have had valvular disorders. And how do we evaluate the effectiveness of our care? We, in most instances, are going to use the medications to control the signs and symptoms. And so we are looking to see if those medications are working properly. For patients that are not surgical candidates, they're poor surgical risks, we are evaluating the care based on the quality of life. I want to spend our last couple minutes talking about cardiomyopathy. There are two main kinds of cardiomyopathy: dilated cardiomyopathy. On the next slide, we'll talk about hypertrophic cardiomyopathy. Dilated cardiomyopathy is exactly that. We see that the left ventricle becomes dilated, the walls become very thick, and the chamber size becomes very large. I'm going to advance it and talk about hypertrophic. Hypertrophic cardiomyopathy is just that. The left ventricle becomes hypertrophic. This is a beautiful picture of that. You see how thick that wall is. You see how little space that left ventricle has. And so with etiology of both, in 90% of the cases, it's idiopathic. Idiopathic in as much as we don't know why people get it. It affects young African American men more than any other group. We're talking about what would be otherwise young, healthy men, 20 to 40 years old, that are affected with this disorder. The cardiomyopathy in left ventricular hypertrophy, left ventricular dilation, like that. Really, we're talking about a condition that leads to left-sided heart failure. So we talk about decrease in exercise capacity. We talk about fatigue and dyspnea and orthopnea. How do we know? How do we diagnose this? Like all the other conditions, with an echocardiogram, 3D TEE or a 3D with Doppler. We want to look at the ejection fraction. A chest x-ray will tell us about cardiomegaly. We want to look at their BNP and pro-BNP, seeing if they do have heart failure. We can actually go in there with a cardiac cath and take a look around, see what's the problem. How do we treat it? We treat it like heart failure, and in many instances, these people are candidates for heart transplant. They go on the heart transplant list because they're young, otherwise what should be healthy. So they go on the transplant list. If they have severe heart failure, we put them on a VAD, a ventricular assistive device that we talked a little bit about with heart failure to bridge them to transplant. And that's how we treat it in the long run. Thank you very much for your attention. I really appreciate it. I'll see you in class where we can talk about this more.